Hi, this is Janaid, Neurocritical Care Stroke and Epilepsy Specialist. We're going to talk about artificial intelligence in stroke. I'm extremely grateful that I've been invited and speak with you at Second Dubai Hybrid Conference. Look, this is a massive topic, so I'm going to just get right into it. It's going to be fast. It's going to be fast-paced. I speak a little faster. But at the end of the day, this will be available on YouTube for further review in the future as well. So let's get into it. Look, I have no relevant disclosures directly related to this talk at all. Stroke is an expensive problem, $861 billion per year. It's about 1.1% of global GDP that goes into stroke care. Well, one of the things that we don't realize is that the grunt of it, the majority of it, 89% of it is in low and middle income countries. It is not in the rich countries. It is actually a very growing problem as we move along. If you look at from statistics from 1990 to 2019, there's an increase of incidence of about 70%. Deaths related to stroke have gone by around 43-50%. And then the prevalence and disability, because people are living longer with stroke and disability, are on the rise as well. So clearly this is a big issue. One of the key issues with stroke is that the latency in care. We know now that time is brain. The minute the patient's vessels are occluded, if we don't get to it, we are going to start losing neurons. How fast, you say? In every minute, 1.9 million neurons are lost. 14 billion synapses are lost. 7.5 miles of myelinated fibers are lost. As a matter of fact, in some large vessel occlusions, which are fast progressors, you can lose a limb in 5 minutes. As a matter of fact, if you get to the stroke slowly, if you do not act fast enough, it's going to take 20-minute delay is going to end up being 3 months of extra disability. That's huge. I mean, living with disability is a huge, huge issue. And we as physicians need to reduce latency. And that's where AI comes in. The question is, why do we need AI? Reduce latency, period. That is the key issue in stroke care. The faster we get to the patient and make a decision as fast as possible, we will able to basically reduce a whole lot of hurt for that particular patient. Now the question really becomes is that is it true? So this is a study that was done by Adnan Qureshi and Amir Hassan, who actually realized that especially in cases where there is transfer of patients from primary stroke center to secondary stroke center, you can potentially save up to 66 minutes. That's a huge amount of time to actually be able to saving for that particular patient. That's actually equivalent to, a complete hemiplegia or not having hemiplegia. So we now have data to prove that artificial intelligence implementation can reduce latency of care. Where do we need it? Now here's another thing that people keep confusing about that. Hey, this is something that we should get in rich countries because it's expensive. First of all, it's decreasing in price. But even if it's not expensive, we have to understand that, well, we don't really have neurointerventionists. You have to understand it's not just about thrombectomies. It's not just about, doing an endovascular intervention. What's been changing is this new trials that are coming, what we call extend trial, for example. Thrombolysis has been the bread and butter of neurological intervention. It is not endovascular intervention, it's pharmacological intervention. And we have extended the time to give thrombolysis by better selecting those patients. As a matter of fact, this extends the time up to 9 hours in wake-up strokes. Clearly, we don't know when it is. With automated cerebral perfusion, we were able to find people that were most suitable to give that intervention even at a later time because we were able to select them better. So therefore, it is not just about intervention. It is also about extending the thrombolytics window. TPA, or teneplectase TNK, either one, make your choice. But at the end of the day, it is definitely one of those things that you as a stroke physician need to look for and potentially advocate for to be implemented in your hospital or care setting. Now, before I get into the actual nitty-gritty within the stroke itself, let me just give you a brief intro so that you understand what the real concept behind it is. So look, artificial intelligence is not just one technology, it's actually a technology enabler. As a matter of fact, there are multiple technologies that are built up. Everything is growing in data. If it's genomics, it's DNA sequences, cloud, Internet of Things, mobile connected devices, autonomous vehicles, whatever that may be, Everything is now generating data, and we have to crunch that data. We have to go higher and higher on the knowledge wisdom continuum. We need to make information into data, data into knowledge, and knowledge into actionable knowledge, which is wisdom. And this is where artificial intelligence comes in. It is not just a technology, it is actually a technology enabler. Now, what is really the artificial intelligence? Now, artificial intelligence is a wastebasket term. I use it because it's just colloquially easy for people to understand. The real term should be used as machine learning. Machine learning is the branch of artificial intelligence we use more so in medicine. There are other branches as well, including robotics in artificial intelligence. However, the real benefit comes from a true artificial intelligence is deep learning, which is a subset of machine learning. When you go from machine learning to deep learning, what happens is that two things need to be done. One, the data and requirement to run those studies are extremely high because more and more data is being used in deep learning. Unfortunately, the downside is you cannot explain your results, and we'll come to that in a minute. So what really changed? Well, look, this is what changed. We have been using algorithms in medicine for the whole time. Hypernatremia, sodium 150, sodium not 150, check FeNA, not check FeNA, what is the volume status, what is not the volume status. We have been using algorithms everywhere. Those are rule-based algorithms. We have been doing that. These were rule-based algorithms that human used to code. We still code them into, different, if x is equal to y is equal to z is equal to d, then do this, right? These are human coders that used to work. Now, we don't do that. What we do in artificial intelligence is, hey, here's 1 million patient records, and this is the result that I want to find out. Go figure it out. We are not giving the computer instructions anymore. We're giving them examples. That's a huge shift in how we actually run machine learning itself, the way we actually function. And that's why the term learning comes in, because we are not teaching by instruction. We are teaching by examples, and that is a complete paradigm shift in the way we have been doing things. And we are going from software 1.0, which was basically where we learned coding and basic sciences, etc. when I was young, and now, which is machine learning, just give examples and let the computer figure it out. Now, what is the real difference between statistics and machine learning? That's important to understand. Well, first of all, you need to understand what is the result. Statistics was all about finding relationships. For example, if you're going to look at Chad's best score, right? So these are the 5 properties of the patient. If the patient has a, prior stroke, patient has hypertension, whatever, and then you come up with a score, and there's a relationship that the person has the probability of having a stroke. It does go into probabilities as well, don't get me wrong. But machine learning is literally all about results. Machine learning is all about prediction. Rather than me going into all these different variables, then running different kinds of statistics, and then sending them into a neatly table, and then codifying them into 1 and 2 only, I'm going to say, hey, here's 1 million patients. Find out who's going to get the stroke. And then, oh, by the way, here's another 10,000, and let me know if this is actually, the results are what they are. So that's a training set. Then there's a validation set, and then there's a test set of data. So that's how we actually do. The second big thing is that with statistics, we are trying to infer what really happened. This is truly a complete shift in terms of understanding what really happened. So we are trying to infer what happened, rather than in machine learning. We don't care about why it happened, how it happened. We just want to know the result. These are 60 figures. Tell me it's a dog or a cat. It doesn't matter how you get to it. And that's another problem with medicine, with explainability. This is not the ethics talk, so I'm not going to get into it. So the statistics is all about relationships, and machine learning is all about prediction. Okay, so how does this actually whole thing work? It's actually quite frankly based on human learning itself. Look, the human vision actually looks at an image, and then goes into the visual cortex, then goes into the auditory cortex, and goes into different layers of neurons, and then tells me that it is a cat. Literally, that's how it works, because there's millions and millions of neurons, and that have millions and billions of synapses. Be honest, this is exactly how artificial intelligence actually also works, especially the machine learning and the deep learning part, in which an image is basically parsed into different subsections, and that image is then run through different neural networks in which they're actually coding at different levels, and then at that point in time then you get the result. Like it's an infarction, hemorrhage, tumor, whatever. So literally it is based on human neural activity. It's exactly trying to mimic neural networks of humans, and therefore, since it's in a computer, that's why it's called artificial neural networks. Now, one thing I want to be clear about before we move on. Look, artificial intelligence is here to support us. It is not to replace us. Look, we're going to add automation in it. We're going to add, some decision support in it. But at the end of the day, the humans are going to be involved in it, period. Look, artificial intelligence is not going to replace physicians. What it is going to do is going to replace physicians who use artificial intelligence with those who do not. So make sure that you learn it. It is the time, need of the time, especially in stroke care, and then moving beyond, especially in neurology, where digital biomarkers are going to become extremely important. Artificial intelligence is here to stay and make waves. One other thing you have to understand is that we're not going to look. There's a lot of sci-fi going on and issues, that this is going to happen, etc. This is not what artificial intelligence is all about. What we're going to see is that artificial intelligence, especially in medicine, is going to develop exactly as software as service. Let me explain. So we're going to have, stroke imaging done with one sort of software service, which is one artificial intelligence. Then we'll have natural language processing going on, and then we'll have trends analysis going on, and this will be the clinical side. Well, what about genomics? What about metabolomics? What about microbiomics? All these are going to be different stacks of software they're going to follow through, and that stacks will eventually get better and better and then merge. So then you will have a true ecosystem of artificial intelligence. But for now, we're going to see areas where these different stacks are going to build independently, and eventually we can merge them and get into that. That is what we call multimodality sort of imaging, multimodality information converging into patients' predictions and decision support. And this is going on already. If you look at Alzheimer's, Alzheimer's is going already and is merging imaging, genomics, and clinical data. However, in stroke, it's still delayed, and we're going to catch up to it as fast as you can. As a matter of fact, there's a whole convergence lecture on YouTube if you're interested. Now let's go to artificial intelligence again. Broadly speaking, there are three things that it is divided into. One is computer vision, the other one is predictive analysis, and the third one is natural language processing. Now, computer vision is all about image analysis and video analysis. Image analysis like radiology and pathology. Video analysis including, seizure, falls, e-sitter, gait analysis, all that we have done. Studies have been done in those cases. Neurorehabilitation is looking at, computer-generated, easy, quantifiable progress, etc., etc. Predictive analytics is basically where you're looking at decision support. The algorithms, the hyponatremia, those are the kind of things that we're going to go with data rather than rule-based algorithms. And then trend delineation and trend analysis, when you have continuous streams of data, EEG, EKG, continuous blood pressure monitoring, continuous pulse ox monitoring to predict, for example, if the patient is going to develop sepsis or not. For example, person is going to develop another stroke or not. For example, person is going to get hemorrhagic, conversion or not. If the person is going to have expansion of hemorrhagic hematoma or not. So those are things that we're looking at trend analysis. And the last, and to be honest with you, most exciting one is natural language processing. In natural language processing, there is speech to voice, where you can develop like voice assistants, chatbots, etc., and vice versa, where they can understand human speech. But more importantly, we're going to see classification of text, extraction of text, summarization of text. About 80% of clinical data is unstructured data, and NLP is the key to unlock wisdom from that unstructured data. So I hope I was able to give you a brief sort of overview in terms of what artificial intelligence is about and what we're looking into. Now let's talk about stroke. I'm going to mainly talk about stroke imaging because that is something you need to understand right away from making sure that you're able to do work artificial intelligence in clinical terms, because it is available clinically right now. Within the process of artificial intelligence, the workflow is basically you get the non-contrast CT. Main concern is ICH dissection, if the person detection, that is, if the person has actually hemorrhage in their brain or not. The second step is to look at aspects. Aspects look at core infarct. If the patient has enough salvageable tissue, if the clinical deficit correlates with the actual core infarct, or is it more than the core infarct? That's where the aspects comes in. Then we move towards large vessel occlusion to see if the CT angiogram can actually predict in a patient that there is a large vessel occlusion. And then we look for automated CT perfusion, and we're trying to figure out if the patient has penumbra, which is by definition means salvageable brain tissue. So those are the things that the workflow goes in, right? So patient walks in and then he gets a non-contrast CT. Now, detecting bleed on the brain on a non-CT from an automated patient is fantastically better. It is getting so good at it. As a matter of fact, people are developing algorithms where you need less and less data. This is a study with a very small data set with 904 cases with sensitivity of 98% and 95%. Huge, very good sensitivity and specificity. And, you can actually get to where the actual, stroke is. You can segment that out possibly. And more importantly, you can even classify them. If the patient has an intracerebral hemorrhage with an intraparenchymal hemorrhage component, with an epidural, subdural, or even intraventricular hemorrhage. So not only you can classify them, but you can also communicate. This is another, contextually available communication that artificial intelligence can implement. So for example, there's an alert as artificial intelligence, then the neuroradiologist gets alerted, he can confirm the findings right away on his phone, and then gets to the next step, and the neuro ICU gets alerted, the neurointerventional team gets alerted, the neurosurgeon gets accepted. This is what we call care coordination, and this is where artificial intelligence contextually aware communication comes in. And again, some of the software packages that are available have care coordination built into them as well. Now, that was intracerebral hemorrhage. Very good, high sensitivity, high specificity. As a matter of fact, to be honest with you, you should develop your own. It's very easy. If the way wants to do it, they should actually implement it countrywide, believe it or not. The second step is aspects. Now, why do we really care about aspects? That's the key thing. Look, I care about aspects because of two things. One, I really need to know what the old strokes are, right? I mean, you have to look at the CAT scan because aspects is going to determine that if the clinical picture correlates with the patient who I am seeing. And the patient I have actually right-sided weakness from a prior stroke 2 years ago, and now is coming from left-sided weakness, and I want to make sure that I'm not looking at something else. So that also determines, how I'm going to proceed. More so, this is the best indicator of core volume, and I'm going to come to CT perfusion when I'm going to talk about it. The aspect score basically tells me that what are the tissue at risk and what is completely core ischemia. And this is actually getting better and better. And there are multiple studies that have been done. Brainomics has done it, Rapids has done it, and all of them has concluded that it is at least as good as, two neuroradiologists when they're comparing it. And therefore, it is important that we actually take that into account. However, I'm going to keep pointing that out. It is important, in my opinion, because you need to know the core when you're looking at it. Aspects is feasible, it is reliable, especially when the M2, M3, territories is concerned, and it is very good for core, as I told you, but unfortunately it's highly variable in two situations. When there is motion artifact, it just sucks. And then second thing is when there's patients who have prior strokes and there's a concern that this is an extension of a prior stroke, or is it the other side, etc., etc., and that area, aspects is garbage, and then you have to go back to your manual sort of understanding, and that's where clinical radiological, association is important. Now let's get to large vessel occlusion. So large vessel occlusion detection is actually also very good now. As a matter of fact, there have been multiple studies that have been done. Rapid did that, and compared with two neuroradiologists, has a better sensitivity. I don't know about that, but at the end of the day, it is extremely good now. As a matter of fact, if you look at the ICA occlusion, you can look at it pretty easily, and then even at M2 level, it is pretty good. The question over here is not being better than neuroradiologists or neurologists or anything. The question over here is basically doing it as fast as possible. It can be done in less than a minute. As a matter of fact, the whole series takes less than 3 minutes. For me to do that manually, making sure that all the images are done, I get the 3D modeling done, I get all the core settings done within the technical side of the CT scanner, this takes a lot of time. So therefore, the benefit over here is not being able to do it. Of course, we were able to do it before. The question over here that it decreases latency for diagnosis. It is very feasible. It is quite reliable and proximal, like ICA, M1, M2, and P1. However, more distally, if you go to M3 and P2, it becomes less and less reliable. And as usual, I mean, all CT angiogram studies are based on bolus timing. If a patient has an ejection fraction of 15% and the bolus timing was not accurately corrected for that ejection fraction, even in non-automated setting, I will not have a good study. In automated study, of course, I won't have a good study either. So those are the limitations that carry over from a non-automated site anyways. Here comes a cerebral perfusion. Now, CT perfusion, of all the studies that we are doing, is most, I don't want to use the word unreliable. I just want to make sure that you understand that, again, this is an automated cerebral perfusion. This is not going to give you a result. You still have to personally interpret those results. What it is doing is, again, it's reducing the latency for getting those lesion maps so that you can make a decision faster. But that doesn't mean that it's going to make a decision for you. It is going to segment it out. It's going to say, this is the core, this is the penumbra, this is the volume that is automatically done, this is the penumbra volume that is automatically done. Somebody's sitting there making the arrows, figuring it out, takes another 6 minutes, and those 6 minutes, the limb is gone, right? That's not what we want. What we want is something that can get it done faster, but we have to still interpret them. Now, as a matter of fact, Pooja wrote this article, and she's going to speak after me, I think. Amazing. The most important article, if you have to read, is this automated CT perfusion imaging for acute ischemic stroke. And then, of course, to understand the real relativity of stroke, you need to read Camilo Gomez's article. So if those are the two articles I highly recommend reading to anyone who's going to take care of stroke patients. Now, CT perfusion has a lot of pitfalls, right? And then it is highly susceptible with patient motion, poor contrast, bolus, brain coverage in CT perfusion is not always accurate. But the biggest issue is that it does underestimate the core infarct. And that's why I keep going to aspects. That's why I keep going to non-contrast CT scans, because you really need to make sure that those maps that are being generated are actually appropriately calculating the core infarct, because it clearly makes a difference, right? If the core infarct is huge, the chances of hemorrhagic conversion is bigger. So make sure you look at the entire study, that is CT, CTA, CT perfusion, and interpret CT perfusion within the light of that whole information itself. So it can never be interpreted without making sure that you have looked at the CTA. Okay, let me give you another example. Now, patient can have a thoughts paralysis after seizure, correct? So CTA is not showing what? A large vessel occlusion. But the CT perfusion is going to show a mismatch. What is a mismatch? The right side of the brain is hyperactivated, and therefore it increased cerebral volume and cerebral blood flow as compared to the red. So the right, and you're going to see a mismatch in between, or there could be even a focal area where there will be a mismatch. What is a mismatch? A mismatch is basically that the blood flow in that area as compared to the blood volume on the other side is not accurately matching. Therefore, there's a possibility that there's a ischemic core versus a ischemic penumbra that is salvageable, that is possibly reversible, but the core is not reversible. So that's what we call mismatch. So in cerebral perfusion, you still have to be very, very careful. You have to make sure that you're looking at the clinical, you have to look at the CT angiogram, you have to look at the CT brain, and then interpret the result. What it is doing, what AI is doing, is only automation of those lesion maps. It is not giving you an interpretation. That's your job. Now, clearly there are more and more software packages that are coming. If you look at Rapid and VizAI, they're pretty now available in US. I think about 70% coverage is there with stroke care is concerned. Brainomics is a software package from UK. clearly has mainly complementary offerings in terms of features. But more and more companies are coming. I mean, there are a list of commercially available software companies that are coming. AIDoc is one of them, which is now FDA approved as well. So we're seeing that more and more commercially available softwares are available for you to take care of. Sorry about that. But to be honest with you, we have not even scratched the surface. Believe it or not, we are literally at the beginning of artificial intelligence in stroke. We can predict a lot of things. We can predict hemorrhagic transformation. We can predict malignant cerebral edema, tracheostomy. I'm going to just go into two of them because of the time reasons. And again, as usual, you can follow me on LinkedIn and YouTube and Twitter, etc. And then I'll be posting some of the articles, videos, etc., etc. Look, one of the key things that we're looking for is post-stroke planning in neurorehabilitation, and one of the hardest things to actually get is a cognitive behavior specialist to accurately measure cognitive decline. If there was a way from an MRI lesion to predict what the neurocognitive deficit of that patient would be, that would be a huge help, and we would have a fantastic way to actually help that patient, and at least with limited resources, okay, this is the one who really needs cognitive behavior therapy and assessment, and this one can wait because this is mainly going to be just, motor deficits. So again, not only implications in terms of diagnosis, but in terms of resource allocation. Same thing, one of the things that I am very interested in is basically the etiology. Look, stroke etiology is a huge issue because it can have post-stroke management consequences. If it is a cardioembolic stroke, you're doing anticoagulation. If it's a small vessel disease, you're doing antiplatelet. We need to figure out better in a way that we are getting to the etiology better. We need to classify that stroke, and we can do that by using natural language processing. Again, these are things that are in development. As I said, software as a service. Remember, different stacks are going to be coming up, and those stacks are going to converge and come into a bigger and better, machine learning towards stroke. As I said, artificial intelligence is a colloquial term, but it is what it is. I have this vision of stroke animation video. You can actually look at some of those things. I also did a paper of role of artificial intelligence in telestroke, where virtual care can actually complement because of the data is more digital in terms of, the patient, you're examining the patient, and then the patient has voice that is dysarthric. Artificial intelligence can pick it up. Patient has, more stiffness. As a matter of fact, we can do that in Parkinson's, flat faces. We have tons of stuff that we can do when the data is digital. So, more and more virtualization of care actually brings more and more data to feed to artificial intelligence. So make sure you read that. And again, make sure you follow. And if you have any questions, I'm active on LinkedIn and Twitter. I'm very grateful for your time. And again, very grateful that you invited me to speak today.
If you save a life, it is as if you saved the life of mankind. Please make sure you like, comment, share, and subscribe to my YouTube channel and my newsletter. If you want to get in touch with me, the best way is to go through Twitter or via LinkedIn. Also, make sure you follow the Academy website for regular updates. Thank you so much.